Yeah, so I'll be quick. So a lot of us refractive surgeons, when we operate, we see the topography and other indices, refraction, go ahead. When everything is normal, we go ahead. But still we come across few patients who develop ectasia. There are many risk scoring factors available in the literature, and we on and off fall on the same PTA, the ERSS risk scoring system, the RSB, the BAD-D values. But still at times, in spite of everything being normal, we do have patients who develop post-LASIK ectasia. So what is the reason of the same? So what are we going to do is to answer the same. It's just the research questions we have framed here, and step by step we'll answer each of it. That what can drive post-refractive surgery ectasia, which is beyond topography. So our group published this paper in BGO in 2016, which clearly suggested that there is a role of inflammation and poor nerve regeneration post-LASIK ectasia. If you see here, these are the nerves on the right hand side. If you can see the post-LASIK ectasia arm, there is low nerve density, immature dendritic cells. There is no crosstalk with nerves, and which is suggestive of poor nerve regeneration post-surgery, which is a sign of subclinical inflammation. We did tear analysis post-operatively for the same patients when they developed ectasia, and it was also suggestive that this patients had raised inflammatory markers in the post-LASIK ectasia group when it was compared to the control, suggesting that this inflammatory markers would have led to collagenolisis, which would have further led to ectasia. Next, we wanted to answer that there are very few cases of smile ectasia reported till date. It's only 7. And we also came across one similar case. So we wanted to answer, is smile ectasia different, or is it inflammatory in nature, or is it following the same trend? If you see here, this is a 26-year-old female patient. We agree it's a high myopia, but absolutely normal topography, good pachymetry, good biomechanics, good pre-op topographical indices, and low risk score. So we did go ahead with a smile surgery for her. But however, to our surprise, she came back to us and she had developed ectasia after 3 years. At this point of time, we were really surprised, and we wanted to answer the question that why did this happen? Why did this patient develop ectasia when she had everything normal preoperatively to begin with? So what had happened was, when she was undergoing a surgery in 2015, we had preserved her lenticule. Dr. Natasha, she was a fellow with Dr. RS that time. She had very meticulously preserved the lenticule at that time. And when she developed ectasia, we could luckily retrieve the lenticule, and we did quantitative polymerase chain reaction for this patient, along with 25 other patients who did not develop ectasia, age, sex, gender, and refraction matched, to study what was going on at the molecular level. So if you see here, these are the extracellular images of the corneal stroma. These are the white bundles which you can see are the collagen fibrils, and the colorful structure which you can see is the LOX enzyme. The LOX enzyme is nothing but it binds the collagen fibrils in place and it keeps it tightly together. But if the LOX enzymes are lower, it leads to ectasia. Similarly, we found in this case, if the patient who developed ectasia had low levels of LOX to begin with before surgery only, which led to collagen weakening, and it led to ectasia. So there was low levels of LOX, which could be a reason for ectasia. And our group has also previously published its role in keratoconus, that LOX, if the LOX levels are low, then there are higher chances of keratoconus, and the LOX levels reduce with increasing grades of keratoconus. So next we wanted to answer that, can all different topography patterns have varied LOX or collagen levels, and can they be different biomarkers or screening tools? So what we did was, all the patients undergoing smile surgery, we started collecting their lenticule with different topography patterns, different pachymetries, and we did the same molecular testing for them. What we observed interestingly was, patients with lower pachymetries or borderline topographies had higher levels of LOX, unlikely the case with normal topography and low levels of LOX. So we understood that the molecular signatures and topography do not match all the time, and they are different screening tools, and we should consider them separate. But what modulates this LOX or collagen levels? I will be very quick in this, as Professor Shetty has already explained this. If there is inflammation, the LOX levels will reduce, and it will also reduce the collagen 6 and the 4 levels, leading to ectasia. So inflammation can induce change in LOX and collagen levels. So are there any factors which can modulate this LOX or collagen levels, or can act as an enhancers? There are many groups working on the same in US and all over the world, like Ivina drops. They act as LOX enhancers, but it's still in the study phase, and we don't have any test for the same. Cyclosporin and trehalose eye drops, which are the anti-inflammatory agents, can also act in reducing inflammation and enhancing LOX. However, our group is right now working on newer agents, which is the vitamin D drops and the medical-based curcumin drops. These are the strongest immunomodulators present in our body. So we wanted to see if this can enhance our LOX levels. So what we did was we created hyperosmotic stress on the human corneal epithelial cell lines, and we created inflammation in them same. When we created induced inflammation, the LOX levels were lower. After that, what we did was we treated them with different combinations and concentrations of medical-based curcumin and vitamin D drops to see how it was doing. Interestingly, what we found was when they were treated with either individually vitamin D or medical-based curcumin, or a combination of same, the LOX levels increased. There was enhancement in LOX levels, and also the vitamin D receptors increased. So as Dr. Palak suggested, if the vitamin D levels are low, then it can lead to pain and other structures. So these drops can actually help in treating a lot of other factors and also potential LOX enhancers. So, do we have a tool to measure this LOX or inflammatory activity preoperatively? Because the procedure what I showed is very elaborate, and not all of us can have access to it. So, how do we measure it preoperatively in our clinics? So, right now what we are doing is we are working on a point of care diagnostic kit where different anti-inflammatory factors and ECM remodelers can be measured preoperatively with just a simple kit, which is a glucometer like kit. How we do it is the antigens are injected in the rabbit models and the antibodies are produced. Once we have this biomarker specific antibodies, they are incorporated in this chip like structure which is in my hand. So once we there will be different antibodies which will be incorporated in this chip, and this chip will go in nothing but this purple device which you can see, which will be as small as a glucometer kit. We are currently trying to work on how the tear activity can be measured with this diagnostic kit. In future, it will be aqueous and other factors as well. So we have already tested the sensitivity and specificity of our kit, and we presume that if we have this kit, we can measure the pre-op activity of LOX and other inflammatory agents, actually treat them with LOX enhancers, reduce the inflammation, and then take them up for surgery for a better outcome of the surgery. Thank you.